This is a post-procedure chest radiograph of an elderly man with enterococcal bacteremia, performed to assess the position of a peripherally inserted central catheter. The film shows a catheter coursing over the right lung apex and terminating near the first sternal wire, an abnormal trajectory for a venous line. This course is more superior and posterior than expected for a subclavian venous catheter, suggesting arterial placement, specifically within the right subclavian artery. A subsequent angiogram confirmed the arterial position of the catheter. A new venous line was then placed, demonstrating a distinctly different path, more horizontal as it crosses the first rib and then vertically directed toward the right atrium. Normally, the subclavian vein passes anterior and inferior to the scalene tubercle, and venous catheters follow a gentle, horizontal course across the upper chest before turning downward into the superior vena cava. In contrast, subclavian arterial catheters travel superior and posterior to the scalene tubercle, following the apical margin of the lung and pointing medially towards the aorta or innominate artery. This anatomic distinction helps identify arterial versus venous catheter placement on radiographs. Arterial placement of a central venous catheter is an uncommon but important complication. It may occur following direct arterial puncture or inadvertently through a transvenous fistulous connection. While sometimes benign, it can lead to significant complications if a large bore dilator or catheter is advanced, including arterial dissection, hemorrhage, pseudoaneurysm, or stroke. When arterial placement is suspected, confirmation can be obtained by sampling blood for gas analysis. Arterial blood will show higher oxygen tension, or by attaching the catheter to a pressure transducer to assess for an arterial waveform. Management depends on the catheter size and patient condition. A small caliber needle or catheter may sometimes be removed with manual compression, but a large bore catheter should never be pulled blindly, as this can result in uncontrolled bleeding or vessel injury. Vascular surgical consultation should be obtained immediately, and prompt surgical or endovascular repair is often required if an arterial injury has occurred. In summary, this case demonstrates inadvertent intra-arterial placement of a peripherally inserted central catheter into the right subclavian artery, recognized by its abnormal posterior and superior course over the lung apex toward the aortic arch. Early identification and appropriate management are essential to prevent catastrophic vascular complications.